My name is Giancarlo Mari. I'm originally from Italy. I've been in the United States for more than 20 years now, and I am an obstetrician, and my title is a professor and chair of obstetrics and gynecology at the University of Tennessee in Memphis. Today I will talk about fetal anemia and how we can use ultrasound to diagnose fetal anemia. And I will tell you a little bit about the history, how we came to diagnose fetal anemia just with ultrasound. Fetal anemia is defined as an hemoglobin value below the 5th percentile for gestational age. There are many causes of fetal anemia. However, in the United States, one of the most uncommon causes of fetal anemia remains red blood cell alloimmunization. Despite the use of ROGAM, which was introduced in 1968 in North America, today it is estimated that there are approximately 4,000 cases of fetal anemia due to Rh hemolytic disease. However, the Rh is not the only cause of red cell alloimmunization because there are many other antigens, the so-called irregular antigens, which may cause fetal anemia. Think about KEL, KID, and others. Alloimmunization from irregular antigens cannot be prevented by prophylactic administration of immunoglobulin because they have not been developed. In 1941, Landsteiner discovered the Rh antigen. It was approximately 10 years later that Bevis reported that spectrophotometric analysis of the amniotic fluid could be useful in the antepartum management of hemolytic disease of the neonate. In 1956, Albert William Lally performed his first amniocentesis. In 1961, he reported the delta D450 curve, and 2 years later, he also reported his first intraperitoneal fetal transfusion. It was 1 year later, in 1964, that Vincent Frieda performed the first intravascular transfusion on a fetus, anemic fetus, at 26 weeks gestation. What Vincent Frieda did is he performed a laparotomy, an hysterotomy. He exteriorized one of the lower extremities of the fetus, and he transfused the fetus through the femoral artery. The procedure was successful, but unfortunately the fetus died within 24 hours from the transfusion. However, 2 years later in Puerto Rico, Adamson performed the first successful intravascular transfusion on an anemic fetus. In 1968, thanks to the studies performed by Vincent Frieda, the ROGAM was introduced in North America, and also thanks to the help of the Sing Sing prisoners who helped for the study. It was in the early 70s that Carlo Valenti, an Italian who was working in New York at that time, reported that Fetoscopy could be used to diagnose open spina bifida and to perform also fetal blood sampling. After that, Charles Rodek in Europe and John Hobbins and Jeremiah Mahoney in the United States started to use fetoscopy to perform intravascular transfusion on anemic fetuses. It was in 1983 that Fernand Dafoe described the technique for cord blood sampling under ultrasound guidance. After this study, a period that I have defined of anarchy started in fetal medicine because many investigators all around the world started to perform cord blood sampling, and unfortunately many times the procedure was unnecessary. For many years, amniocentesis and cordocentesis have been used to diagnose fetal anemia. However, both procedures are invasive. Amniocentesis is invasive. It is not reliable before 27 weeks gestation. We do not know what is the optimal frequency of repeated sampling. For example, if we do an amniocentesis and the delta D450 is in a safe zone, we don't know when to repeat the procedure. In a week, in 2 weeks, in 4 weeks, nobody really knows. In addition, amniocentesis does not appear to be reliable in KEL sensitization because with KEL, the problem is not the hemolysis, but the problem is the suppression of the erythroid precursors at the level of the liver, spleen, bone marrow, etc. And amniocentesis can also be associated with worsening of maternal alloimmunization. And here it is reported the Lally graph with the 3 typical zones, 1, 2, and 3. And as you know, with the Lally graph, we measure indirectly the bilirubin in the amniotic fluid. Therefore, if there is hemolysis, the bilirubin will increase, and also the value reported here on the curve will increase. Now, if the value is in zone 1, the fetus is non-anemic. If it is in zone 2, the fetus is probably non-anemic, but is maybe becoming anemic. And if the value is in zone 3, the fetus is most likely anemic. The green dots here represent the values of the delta D450 on a fetus who was not anemic during gestation, and he was not anemic at birth. However, his mom underwent 6 amniocentesis, so therefore 6 unnecessary procedures. Now, what about cordocentesis? Cordocentesis is more invasive than amniocentesis. We do not know what is the optimal frequency of repeated sampling, and cordocentesis may also be associated with the worsening of maternal alloimmunization. In addition, risks of cordocentesis are infections, fetal bleeding, bradycardia, PPROM, and fetal demise. For many years, investigators have tried to use ultrasound to determine if the fetus was or not anemic. One of the parameters that was suggested was the diameter of the umbilical vein. Other investigators like Hopkins and Badosing have suggested the use of the spleen circumference. Others like Alistair Roberts and who has suggested the liver measurement, the circumference of the liver. Others like Benasseraf and Nicolini suggested to look at the ascites. At the end of the 80s, we came up with an hypothesis, and we said if the fetus is anemic, the blood viscosity decreases and the cardiac output probably increases. The consequence of these 2 effects is that the blood velocity must increase. And before I continue, I would like to give you a few concepts in Doppler ultrasound. And in this slide, it is represented the relationship between the cosine of an angle and its value. And as you can see, if the cosine of an angle becomes greater than 0 degrees, the value becomes smaller than 1. Therefore, when we want to obtain the blood velocity, we need to make sure that the angle between the ultrasound beam and the direction of the blood flow is very close to 0 degrees, because if the angle is greater, we will underestimate the velocity because the value, as you can see, will decrease. Now, with our machines, we can either underestimate the blood velocity, or we can also overestimate the blood velocity when we use an angle corrector. In practical terms, it is not always easy to get an angle of 0 degrees, and that is the reason why when we do Doppler ultrasound of the fetus, often we use indices which are angle independent. Now, if the blood velocity is directed toward the transducer, the waveforms, the Doppler waveforms, will be represented above the baseline, whereas if the blood flow is directed away from the transducer, the waveforms will be represented below the baseline. Here you can see the color Doppler of the circle of Willis, and the color red and blue indicate the direction of the blood flow. Red here indicates that the blood flow was directed toward the transducer, and the blue indicates that the blood flow in this case was directed away from the transducer. Here you can see flow velocity waveforms of the middle cerebral artery. To the question, is the blood velocity in systole, actually is the peak systolic velocity, which is the highest point of the waveform, which is in this case is equal to 56 centimeters per second. And is this the real velocity of the blood flow in which it was obtained? The answer would be probably yes, because the angle between the ultrasound beam and the blood flow, as you can see here, the middle cerebral artery in red, are very close to 0 degrees. And therefore, this 56 centimeters per second is the real velocity of the blood flow. Here you can see the steps that we have described at the beginning of the 90s, but we did another study at 2 different institutions with Dr. Abu Ahmad in 6-7 years ago. And these are the steps that we should use when we want to measure the real blood velocity at the level of the middle cerebral artery. As you can see, these steps are clearly defined, but the most important concept is that the middle cerebral artery should be imaged for its entire length, as here reported, and the waveforms should be all similar to each other. This is a small video clip. It is an old video clip which shows the steps that are needed to correctly sample the middle cerebral artery. Here you can see the circle of Willis. Here there is the middle cerebral artery, and as you can see, the middle cerebral artery is visualized for its entire length, and the sample volume is placed very close to the origin of this vessel from the internal carotid artery, and the waveforms should be all similar to each other. Usually when I look at the blood velocity at the level of the middle cerebral artery, I repeat this at least 3 times. And when I see that I get a consistent value, I consider that as the real value of the blood velocity. Here you can see flow velocity waveforms of the middle cerebral artery with advancing gestation. And here you can see the reference range of the middle cerebral artery peak systolic velocity with advancing gestation. And the green lines, of course, represent the reference range, whereas the yellow dots represent the values from which the the reference range was obtained. In 1990 we did a study, and in this study we went to look at the middle cerebral artery peak systolic velocity obtained in fetuses who were anemic at cordocentesis, and we plotted the values above the reference range. And what we saw is that in many cases the blood velocity was above the upper limit of normal. However, there were many other cases in which the blood velocity was within the reference range. We were a little bit disappointed when we saw this data. However, we said the middle cerebral artery peak systolic velocity, as measured by Doppler ultrasound, is increased in anemic fetuses, and unnecessary procedures can be avoided. There was something that we were missing. And what we were missing was the relationship between the hemoglobin, and here it is reported as multiples of the median, and the middle cerebral artery peak systolic velocity reported as multiples of the median. There was one of my former fellows, Utgo Oz, who was studying with me this, and I remember that when Utgo showed me this graph, I think that we realized what we had missed for a long time. The concept is that if the fetus is mildly anemic, the middle cerebral artery peak systolic velocity will not change much. However, if the fetus becomes anemic, the blood velocity increases, and there is almost a linear correlation between the velocity and the hemoglobin. With this in mind, we organized a multi-center study which was conducted at 8 different medical centers from all around the world. And the first step was to obtain the reference range of fetal hemoglobin with advancing gestation. And here you can see the reference range of the fetal hemoglobin. The green dots represent the values from which the reference range was obtained. And all these values were obtained at cordocentesis. We also defined the anemia as mild, moderate, and severe. After that, we went to plot the hemoglobin values obtained in 111 fetuses who underwent a cordocentesis because, based on traditional criteria, they were defined to be severely anemic. And what we found is this. First of all, we realized that approximately 70% of the fetuses had an hemoglobin value either in the normal range or they were mildly anemic. And among the fetuses who had moderate and severe anemia, 30–40% of them were hydropic, the red dots, at the time of the procedure. Therefore, we were performing more than 100 procedures in reality to detect approximately 20 fetuses. And we were doing a lot of unnecessary procedures, and many fetuses were dying because of an unnecessary procedure. We also looked at the middle cerebral artery peak systolic velocity in all fetuses, and by using the cutoff of 1.50 multiples of the median, which was obtained through the ROC, a receiver operating characteristic curve, we realized that if we had used this cutoff, we would have detected all the anemic fetuses, and we would have avoided approximately 70% of the procedures. In this study, we said the conclusion was that the sensitivity of the middle cerebral artery peak systolic velocity for detection of significant fetal anemia is approximately 100%, at 12% false positive rate. We also found that in Alloimmunization, the correlation between middle cerebral artery peak systolic velocity and hemoglobin is good. And this is the curve that we have used since we did our study 11 years ago, where you have the median and the 1.50 multiples of the median. You have on the y-axis the middle cerebral artery peak systolic velocity, and on the x-axis the gestational age in weeks. After that, there were many investigators that said that this is a good study, but in a certain way this is a retrospective study because you have not used the middle cerebral artery for timing a cordocentesis. So with this in mind, we organized another study. Actually, this was organized by Roland Zimmermann, one of my friends who is now chairman of OBGYN at the University of Zurich in Switzerland. In this study, there were 5 tertiary referral centers. There were 125 fetuses at risk for anemia, and the middle cerebral artery peak systolic velocity was used for timing a cordocentesis. In this study, we did not do a cordocentesis in 90 fetuses. We performed 35 cordocentesis, some were unnecessary, and we missed 2 cases of anemia. However, the interval between the last exam and the delivery was greater than 3 weeks. Up to now, we have talked about the middle cerebral artery peak systolic velocity that can tell us if the fetus has or not significant anemia. However, if we look at one value, when do we need to repeat another value? If, for example, a fetus is not anemic, do we need to repeat the study in 1 week or maybe 3 weeks? And this is the reason why we did another study. We went to look at at the middle cerebral artery in fetuses at risk for anemia and in fetuses who were not at risk for anemia. We followed these fetuses longitudinally, and here you can see the regression line of individual fetuses, non-anemic, the black lines, and the fetuses, regression lines of fetuses who became severely anemic. As you can see, the slope of the curves is different. Even when we went to look at the fetuses who were mildly anemic at cordocentesis, we found that the slope between the normal non-anemic fetuses in black and the mildly anemic fetuses was different. Okay, so we developed this graph. Based on this graph, we repeat the scan between 1 and 4 weeks. And what we do today is this. If the values we obtain the middle cerebral artery peak systolic velocity in fetuses who are at risk for anemia at a week apart. We obtain 3 values, and after that we look at the regression line. If the regression line is to the right of this green dotted line, we repeat the scan between 2 and 4 weeks. For example, if the patient is at 20 weeks gestation with no history of a previous fetal anemia, and she has a titer of anti-D of 164 or 1/28, and the regression line is to the right of this green dotted line, we repeat the scan in a month. We don't bring the patient back in a week or 2 weeks because it is not necessary. Whereas it is between the green and the yellow red line, we repeat the scan usually in 1 week, and if it is to the left of the red line and the middle cerebral artery peak systolic velocity is still below the 1.50 multiples of the median, we repeat the scan in 2 or 3 days to see if we can confirm the values or not. Today, we are more rarely using this graph because we just look at the trend, and by looking at the trend, I will say that for the last probably 8 or 10 years, we have not missed any anemic or severely anemic fetus, and we did not perform any unnecessary procedures. There are many studies which have confirmed that fetal anemia is a good tool that the middle cerebral artery peak systolic velocity is a good tool to look for fetal anemia. But I would like to ask some questions. Which patients are candidates for the assessment of the middle cerebral artery peak systolic velocity? First of all, patients should be at risk for having an anemic fetus. because if the fetus is not at risk, there is no reason to look at the peak systolic velocity. Where do we need to sample the middle cerebral artery peak systolic velocity? And we have learned that by sampling the middle cerebral artery peak systolic velocity soon after its origin from the carotid, there is the lowest intra and inter-observer error. How do sonographers and sonologists achieve a good training? Well, first of all, sonographers and sonologists should become familiar with the steps for the middle cerebral artery peak systolic velocity assessment, and at least at the beginning they should contact centers for advice, of course centers with experience. Is the delta D 450 better than middle cerebral artery peak systolic velocity or vice versa? In 1997 we reported that the middle cerebral artery peak systolic velocity was at least as good as the delta D 450. These data were confirmed by Pereira and by Hopkes. Actually, Hopkes was the leader author of for the Diamond study group. This study went to compare Doppler of the middle cerebral artery peak systolic velocity versus amniocentesis to predict fetal anemia. And the study showed that the Doppler of the middle cerebral artery peak systolic velocity performed better in terms of sensitivity, specificity, positive and negative predictive value when compared to the amniocentesis. And this, I think, was really a great study. Now, based on this, to the question, is the middle cerebral artery peak systolic velocity standard of care for the diagnosis of fetal anemia? I think that today the answer probably can be yes, it is. It has, at least in the United States, and I will say in many areas of the world, has become the standard of care. Now, it is also true that some investigators continue to do amniocentesis, but I think that it would be very important today to tell the patient that there is, if somebody wants to do an amniocentesis, the patient should be informed and told that there is a test that is less invasive than amniocentesis and it is better than the amniocentesis. And after that, the patient, of course, can choose. And I think this will be important to talk to the patient because of legal issues that could arise in the future. Today, also the American College of OBGYN has recognized the middle cerebral artery peak systolic velocity as a good parameter to use in cases of fetuses at risk for fetal anemia. And what has to be the management algorithm of fetal anemia today? I think that it is synthesized here. And this can be found on many textbooks. The only difference with what is found still in some textbooks is that instead of amniocentesis or cordocentesis, we should report middle cerebral artery peak systolic velocity sequential studies. Is the middle cerebral artery peak systolic velocity reliable in fetuses previously transfused? There is a study that is going on now, organized by Greg Ryan and is a group in Toronto and with Nelson and other fellows all around the world. I probably will get an answer in 4 or 5 years about this. Although I think that today the most important concept is that the middle cerebral artery peak systolic velocity is important to diagnose anemia at the beginning, because after that I think that will be, in a certain way, it's easy to manage an anemic fetus after that has been transfused. Is the middle cerebral artery peak systolic velocity reliable for the diagnosis of fetal anemia due to other causes? And the answer is yes. There are many studies now in the literature which have reported that the middle cerebral artery peak systolic velocity is useful in cases of parvovirus infection, fetal-maternal hemorrhage, non-immune eye drops, in cases of monochorionic twins following the death of the co-twin, and in cases of twin transfusion syndrome following laser therapy. I would like now to show you some examples and to see how we are using the middle cerebral artery peak systolic today. And by doing in this way, as I said before, we have not missed any case of severely anemia, I will say probably for more than 10 years now, and we have not performed any unnecessary procedure based on the middle cerebral artery peak systolic velocity. This is a case number 1. The patient was a 33-year-old, gravida 3, with an anti-D of 1/64, and she had an increased delta D 450 in the amniotic fluid. The fetus was Rh positive, and she underwent a cordocentesis at 22 weeks, but this was unsuccessful. The patient was referred to our group at 22 weeks and 1 day, and this was the delta D 450 that had been done previously by another group. And when she came to see us, we gave her several options. Try cordocentesis again, wait for signs of eye drops, or look at the middle cerebral artery peak systolic velocity assessment. She opted for the middle cerebral artery peak systolic velocity, and the first value was below 1.50 MOM, and after a month, approximately a month, the value became above 1.50 MOM. At that point, we did a cordocentesis, and the fetus was anemic, was 7.4 grams per deciliter, the hemoglobin. And here you can see the trend of the MCA, of the middle cerebral artery peak systolic velocity following the transfusions. As you can see, after the transfusion, the value drops, decreases. This is another case. The patient was KEL sensitized. The anti-KEL titer was 1/512. The fetus, because of an amniocentesis, was KEL positive, and the patient opted for middle cerebral artery peak systolic velocity assessment. The first value was very close to 1.50 MOM, but in a couple of weeks, this value, there was a sharp increase of the value. We did a cordocentesis, and the hematocrit was 17%. The baby was transfused to 31%. The velocity decreased, and after increased again, and after decreased again after the cordocentesis. Case number 3. This was a case of anti-Duffy, and the value went from 128 to 1/512. We started to follow the patient with middle cerebral artery peak systolic velocity, and the values were all below the 1.50 multiples of the median. However, the titer went to 1/1024. I think we continued to follow the patient with the middle cerebral artery. We did not do any procedures at that point, although we became very nervous because of this value. But the baby delivered a term, and when the value was repeated in the mom, it was 1/256. And the baby was not anemic at birth, actually was 41%. The patient was a 28-year-old, primigravida at 36 weeks of gestation with decreased fetal movements. She had been seen in the office, in the private office the day before, and the NST was reported was reactive. She came back to the hospital the day after, again with decreased fetal movements. Here you can see the typical sinusoidal pattern, but also we looked at the middle cerebral artery peak systolic velocity, and the value was 110 centimeters per second, well above the 1.50 MOM. Anyway, the patient was delivered by C-section. The hematocrit was 7%. Anyway, the baby was transfused and did well. In conclusion, the middle cerebral artery peak systolic velocity is an excellent tool for the diagnosis of fetal anemia. Many babies today will live a healthy life because of middle cerebral artery peak systolic velocity. It is important to emphasize that training of sonographers and sonologists is indispensable. And thank you.